All right, good afternoon, everyone. Thank you for joining us for this month's Updates in Pediatrics live stream. Participants will receive a link following the program for an evaluation. You can also use the QR code that will be displayed following the live stream today. Updates in Pediatrics is a monthly live stream program which takes place on the third Wednesday of the month at noon, and the program will be available online within a week or so at nortoncme.com. So today I'd like to introduce our speaker, Dr. Mark Cheriker. Dr. Cheriker received his medical degree from MUSC and is a veteran of the US Navy. He did his residency in general surgery and fellowships in plastic surgery and hand surgery. Dr. Cheriker is the service line chief for plastic surgery at Norton Children's Hospital and has many areas of interest, including cleft lip and palate surgery, complex wound care, vascular lesions, and hand and facial deformities. So today, Dr. Cheriker will be talking to us about the identification and management of common congenital anomalies seen in the pediatric office. So I'll turn it over to Dr. Cheriker.
Okay, thank you everyone out there. I can't see your faces, but I'm going to assume you're out there. I'm going to take some time to talk about many of the complex problems we see and that you see, and tell you about how we manage them and how I've partnered with our teams at Children's Hospital and partnered with the pediatricians in the community and around the state to solve some of these problems. Okay. I have nothing to disclose at this time. One of the teams that we commonly work with is the Craniofacial team. And we do about 150 cases a year here at Children's. We partner with the pediatric neurosurgeons, the ICU attendings, as well as the support staff with physical therapy and orthotics and our surgical team to solve these problems. One of the most common problems that we see are craniosynostosis. And this is a beautiful, as you see here, physiologic device to lay down bone with stress of the growing brain. But based on the sutures, either the metopic, the coronal, the sagittal, or the lambdoid, there are characteristic findings that you'll see clinically that'll help give away to the diagnosis without even getting a CT scan. For instance, in this particular child with myotopic synostosis, you see the front keel of a ship appearance of the forehead, and the compensatory changes that we see create the characteristic findings we see clinically, which is trigonocephaly. Now, the surgical treatment of these is simply to release the on. If we get them before 6 weeks, we can often just do a suturectomy with a limited incision with a 1 to 2 day hospitalization, and they're out. And then we remold them and reshape them with a cranial molding helmet post-op. Here you see this child with fairly hypotelorism. The eyes are a little closer together. We release the suture in this way. We remove the suture this way, metopic suture, and over time they grow fairly normally here, as you can see, at about 3 years of age. Here's a characteristic finding we see with coronal synostosis. And here you can see the characteristic fused suture line in the coronal suture. And then you see the compensatory changes in the face with bossing of the contralateral normal side, the typical harlequin appearance of the orbits in the face where it's flat and the eye is proptotic due to a shallow orbit. And you see dystopia here in the eyes, one's higher than the other, and a misshapen nose where it's pushed away, as you can see in this film here, from the distortion and the lack of growth from the lack of having this coronal suture open, laying down more bone. So again, hysterectomies, and another procedure called distraction, which we'll talk about in a moment. Here's the most common one, synostosis case we see, which is sagittal craniosynostosis. And if we get to these early, we could do just a simple suturectomy and remove them with a helmet. If they're later on, like in this child, where you see the characteristic frontal bossing, the sharpness of the posterior cranium, consistent with sagittal synostosis, and then we go on and have to do barrel stay procedure where we actually cut the bone in several areas to open up this narrowed area, which has not been allowed to expand. I just wanted to put this in just to show you on the syndromic cases, there are actually mutations in genes that are very complex, and the pathways for these are very complex. So I don't think we're going to find anything in the future, in the near future, to try to resolve these or treat this from a genetic standpoint. Sorry. I'm having a technical problem here. Now let me take you through a syndromic case, and this is a case of Aper syndrome, and very similar to Cruzon syndrome, with the exception of the pansyndactyly of the hands. Here you can see the coronal suture in this radiograph that has been fused. There's a closed suture here. This is the surgical procedure we do, which is a frontal orbital advancement. And we expand the cranium and we advance the upper orbits as well. Here you can see the orbits from a frontal view, and actually see there are actually absorbable plates vertically here, here, and here, where we stabilize it temporarily, but those plates go away over the course of a year. And you see from the proptotic eyes, improvement in the volume of the orbital vault, where the eyes are better accommodated. And the next procedure for this child is going to be the distraction of the upper mid-face area, where it's very, very short, just a few centimeters between the orbits and the upper jaw. Now, another technique we're using is to expand the posterior cranial vault more, as well as doing a suturectomy to increase the volume, because that operation, the frontal orbital advancement, is a static operation. Nothing much goes on afterwards. Continue to fight the scarring process that goes on after surgery. But by adding a distraction technique, we've been able to do something more dynamically and add more volume that goes on for several months after the operation, along with a suturectomy to give them more of a cranial vault and more volume for the growing brain, which occurs rapidly over the first 2 years. This is just to kind of signify that we address the problem early on in life, but later on in life, we have to treat the problems that occur from lack of appropriate bone growth afterwards. And here you see, by virtual surgical planning, we're able to find and manufacture plates that go in to fill these gaps later on. Now, the next thing I want to get into is plagiocephaly. Plagiocephaly is a common problem you see in your office as well as I. And I want to just kind of show you how I go through this and try to treat it and manage it. I use the Argentus classification system 1 through 5, and there's 5 main points that I'm looking for. And I will just go through that. Here in this child, you see left occipital flatness with contralateral flatness, kind of an obtuse forehead on the right side. This goes along with a parallelogram, which is more consistent with plagiocephaly, not craniosynostosis. So I don't necessarily have to get an x-ray for these children. And so that's one component. The other component is that more angular sharpness on the same side as the flatness in the forehead. The third component is the ears. The ear canal, if you put your finger in the canal, this one's going to be more forward. And so the skull base is asymmetric as well. So that's the third component. The fourth component is the facial asymmetry, which is not well demonstrated in this 2D image, but in the live state and examination, you can better appreciate it. And the fifth component is more peaking of the vertex area here, where there's compensatory changes too, in more severe cases. So this child has 4 out of 5 of those features for type 4 plagiocephaly, and I'll most likely put this type of child into a helmet. And we try to get to them between 4 and 6 months of age. Here is just an overview of those findings 1 through 5 that I discussed. And in brachycephaly, where there's more transverse advancement because of the flatness than there is AP growth, those children will sometimes require a helmet as well. That's a matter of judgment. And these kids really love these helmets, as you can see, but they get through it and they adapt to them fairly well within a few weeks. And the standard treatment for them is going to be, I tell the parents, 3 months, 22 hours a day. This is a particularly difficult problem that I see with plagiocephaly. When I see this with Torticollis, it's a much more advanced case usually. And so in this particular child, he's not going to really get better with his Torticollis until he's able to motor around and ambulate, because he is fixing his vision in this position. If I try to straighten his head, he will have a dystopia and he will not have, he'll have almost double vision. So he can't focus well in this position. So this is his natural posture now until he gets older. So we also like to rule out scoliosis and so forth in these children and make sure they don't have curvature of the spine. So in Torticollis, it can be from tumor, infection, the sternomastoid muscle, injury during the delivery, and this problem is usually managed with therapy. I use Botox in patients who have cerebral palsy, but that is very rare for me to manage that. And surgery is reserved for those patients who have a fixed lesion that is not amenable to therapy. Let's just go through one of the Torticollis patients and see. You can see the child tries to elevate her head to the other side, and it raises the shoulder, and that is a fixed, firm lesion that you can palpate. And here we surgically release it, and I have to actually release both heads of the sternomastoid muscle and invoke aggressive therapy afterwards to prevent recurrence, which is a problem. Now I'm going to jump over to congenital vascular lesions, which is a very keen interest of mine. One of the very difficult areas of vascular malformations, and these occur at the time of birth. They're present at birth and can be rather dramatic or not so dramatic, or very subtle. They can be lymphatic in origin, they can be venous in origin, and they can also be capillary in origin, which is the most common one that I see. Now, congenital hemangiomas are lesions that are kind of unusual. They're full grown at birth, and we have a rapidly involuting type and a non-involuting type, which I'll go over in a moment here. Often confused with infantile hemangiomas, but treated very similarly. Now, endotheliomas is a fairly rare vascular lesion that we see at birth and very deceptive, but these lesions can actually change into a malignant lesion and are very subtle. That's why it's good to perform a biopsy on some of these lesions. Now, the most common problem I deal with is infantile hemangiomas. That's where we don't see anything at birth, but they can rapidly proliferate and create destruction, which we try to prevent early on. And then they have an involution phase in some of them, which we'll talk about here briefly. Let's touch on a very common lesion. The most common lesion I see are port wine vascular malformations, just a capillary malformation. You see this pinkness in these children, and I think it's more of a neurogenic problem where the blood regulation to these areas are not fully developed. Some people argue that it's more growth of the vessels, but I think this is just in the capillary and there's lack of regulation. There's no surgical procedure for this to treat it or remove it, but the best thing that we have is laser. And the laser is called pulse style laser, and it's tuned to a frequency that is where it's absorbed by red at 600 to 650 nanometers, and that will cause collapse and ablation of these vessels to some degree. So we do serial treatments, try to keep them light. And the reason I have Gorbachev's image over here is because this is what they can become. They can become a more ruby red port wine coloration if they're not treated. And the bigger lesions, such as these, if they're untreated, they can change to that and become very deforming later and also create some nodularity. This is a congenital hemangioma. This was present at birth, and you see there's no subcutaneous component really. It's more superficial. And with a combination of laser and time, well, we can clear those lesions pretty well without doing any open surgical procedure. Now here's a typical infantile hemangioma. The cat's already out of the bag on this one. There's a significant subcutaneous component to it. And once I see that, I do not see these involute ever. They get softer, more boggy, they turn blue, they're more supple, but they never go away. So what we like to do is shut them down as early as possible so they don't destroy more tissue, because this is removable and fixable. If the larger they get, the more of this penetration they get, the more of that type of tissue we need to remove when we excise them. And so let me take you through the treatment of that. So once I see these subcutaneous components, that's the boggy mass that will be there forever. And so we can resect those and be done with it and close them up. And I try to defer the surgery until they're about a year of age, just for the safety reasons for anesthesia and that issue. Now this is a particularly complex lesion that I'll take you through. And this is another infantile hemangioma that really got out of control before it got to me. But once I saw them, I tried to treat them medically to no response. Here you can see it's ulcerated, it's scarred down, it's obstructing the field of vision. It really needs to come out early on. So let me go through some of the medical treatments. So high-dose steroids was the method of choice when I came into practice. And that has since been replaced with beta blockers. And is one of those serendipity issues where a patient in England was treated with a beta blocker because he had congenital heart disease, and the hemangiomas in his child got better. And since then, since that was reported, everyone has moved over to the use of beta blockers. And then in early resection, in some cases, when there's field of vision issues early on. So let me just take you through the treatment of this child. Here I resect the lesion. This child is not a year of age, and you see there's some hemoclefts in the surgical wound. The lower lid I left alone, and then we closed them up. And so as we go from left to right, you see we still have some residual lower lid to take. And so with laser and excision and skin grafting, laser, excision, and skin grafting, we finally get to this point. And the last little bit, because of the negative vector of the eye, required a little bit more replacement of this skin graft material and resurfacing. And I'll show you how I did that. We put a tissue expander in this child, expanded this normal skin over here to replace this abnormal skin and also support the lower lid. And here we replace that and support the lower lid. Now there is more of a positive angle here to the lateral commissure, and the lower lid's better supported. But there's still been overgrowth of bone and tissue, and still a little proptosis because of that. It's another child who has a hemangioma, and you see the ulcerations, and this is involved when they involve a particular vessel, such as a labial vessel. They tend to hang around a little longer and hard to get rid of, but with propranolol, this lesions shut down, scarred, and you can see the scarring in this child. And we let it mature a little bit more. And when we get past a year of age, then we start looking at reconstructive options. And in this child here, you see the lesion is now matured. It's not going anywhere. It'll be there for life. So now we look at the vermilion, all the structures that are left behind, and we can put that lip back together after resecting it and get her started back to where she needs to be. Now, in this particular child, there's a series of laser excisions. Here you see some in the nose, and we have some approaches. We get that without too much scarring and carefully try to resect a laser and try to get her to a good point. Because you just never know how these children are going to end up. And so we don't want to leave any particular scarring there if we can prevent it. This is another interesting lesion, moving away from vascular malformations to lesions that look like vascular malformations or hemangiomas. And this is called a pyrogenic granuloma. Characteristically, it will get knocked off repeatedly and bleed and come back and go through that cycle over and over again. So these can be excised once and for all, and but they have to be closed with local flaps over top of the base of the soft tissue and to prevent recurrence. And we think these are traumatic, although the history of that, not many children will give you a history of being injured there. Let's talk a little bit about cleft lip and palate, which we have here in Louisville. And our team is sanctioned by the Cleft Palate Association out of Chapel Hill. And we're supported by the state government as a mandate to take care of children with craniofacial and cleft lip and palate disorders. And we have a great team of people out there that give their time from dental to oral surgery to ENT to speech pathology, our social workers as well, orthodontists and so forth. And we partner with people around the state to take care of these people in their own communities. One of the first things we do with these children that we suspect have clefts, they're now screened, and you can detect them with an ultrasound. And here's a nice ultrasound that shows bilateral clefts. And so when you get these patients in, the families, they're now prepared for the delivery. And you can show them pictures and really counsel them on what to expect, and it gets them through it a lot easier. And in this particular child is bilateral facial and cranial clefts that are quite severe, and it's quite a dramatic picture to wake up to for your first child that's delivered. So this preparation is essential for patients, and our neonatologists are good about getting them for initial counseling. Just to talk a little bit about cleft lip and palate, most of the operations that make a significant change in them, they're done in the first year. The lip and palate can be repaired. They can present in any combination of a complete cleft lip, complete cleft palate, incomplete cleft lip, and no cleft palate on this side. And then we also see it with bilaterality and there's bilateral clefts that are equal. So we try to get them to a good place before they start school so they can blend in and be successful in their lives and can mainstream. And so I'm going to move on to another part of the facial clefts, the facial clefts and the cranial clefts, and just to briefly talk about that. And this was first classified by Tessier, who has been one of the forefathers of craniofacial surgery. And so with this classification system, we have a combined way of how to manage these problems based on the type of cleft we're dealing with. Now, this is a child that's been adopted, and these are quite remarkable families, and we have several of them here in Louisville that I take care of their children, and they go out and seek the worst problems and when they adopt children, and they bring them into their care and our care, and we're quite privileged to take care of them. So this child has a facial cleft and cleft lip and palate and a cranial cleft all the way up into the orbit with anophthalmia, and this globe is not functional, and you see it's not stimulating growth in the orbit to be this type of orbit. So let's take you through a management of where these children. And so here's cleft lip repaired, cleft palate repaired, and we get here, and then we start lengthening and improving the orbit so that we put a prosthesis in that area to normalize them as much as possible. And so here we are putting, repairing the cleft lip and palate, and then we're putting a bone graft, a rib graft in here to create an inferior orbital rim to help restore them to some degree, so that we can put them into a better place. Not perfect, but once we get a prosthesis in here, we'll be in a better place. Now, just a word about the families who take care of these. When families do well, the children do well. If the families don't adapt well to these problems, the children have difficulties. And so in this particular family, all these children have an anomaly, and all of them are undergoing treatment. But they're very happy children, and they're well adapted because they have excellent parents, and they become successful and able to, they will be successful, and they will take care of themselves in this way. Now we're going to switch gears a little bit. We're going to move over to our Airway team in the hospital. This involves intensivists, our ENT Airway group, sleep medicine, ped surgery, and plastic surgery. Plastic surgery comes into this area when there is a upper airway obstruction from the mandible. And I'm going to take you through that next. This is a very common problem we take care of, the Pierre Robin sequence. There's 3 components to that. The tongue is floppy. There is a high arch palate or possibly a cleft palate, and then there's micrognathia. And the micrognathia, and as you can see here, it's a wide cleft. There's the underside of the tongue, which is characteristic, falling back into the cleft. And this is glossoptosis. And here you can see the mandible is short. That should be more further out. The tongue is rotated back and is ptotic, and it's obstructing the upper airway. And so our treatment for that is to divide the mandible here, and then we put an internal distractor and overcorrect them, really. And when we pull the mandible out, it pulls the tongue out. And I'll show you that in a moment here. Here's a child from the side view, retrognathic, very deformed, small mandible. So we go in, we make the internal cuts of the mandible. This is an external distractor, and then we crank them out, so to speak. And over time, it gets the tongue out of the way and opens up their airway. Now let's look at a case of that. This is a common distractor we use now called a 2-pin distractor. We put the pin across the proximal mandible and the distal chin, and then we go in with an ultrasonic saw and we divide the mandible and try to protect the nerve, and then this device distracts them out. And here you see the case where the tongue is now more forward. This airway strip in this sagittal view shows an open airway, and the child is sustainable and doesn't need a trach. Tracheostomies are dangerous in little babies. They can be lethal if they get plugged, and no one catches it. Here's an overdistraction in a child with Treacher-Collins syndrome, and it looks really abnormal, but this really settles back quite nicely. And if we could keep them growing, that would be great, but they slow down. But the objective of this distraction technique is to get the airway opened up and get them out of the hospital. We're switching gears again. And so this is a common problem that can be lethal called cutis aplasia. We see little patches of skin in the scalp where there's cutis aplasia, but this is the more significant problem we see that could be lethal. Reason being that it's right over the sagittal sinus, and if that breaks down and bleed, the children can bleed out, which has happened. So here we get them to a good place where we're skin grafted, but we have a cranial bone defect here, as well as this alopecia here. So let's take you to the treatment of that. Here you see no hair-bearing scalp over here, which is not attractive for a child going through the early years of school. Here's a cranial defect where the brain is exposed to possible trauma. That's not acceptable either. So here we put tissue expanders in this child, and then what we do is come in and reconstruct the cranial bone and protect that sagittal sinus there. And we take out the excess non-hair-bearing skin. And we get a fairly good result on this technique of expansion and reconstruction. Now let's talk about midline problems, and this is a real scary area. And a very common lesion that I see is a little dot on the tip of the nose. No one thinks much about that, but these are called nasodermoids. They could just be right there, or they could tract all the way up into the brain. And we have to be careful about that. If they do that, then the operation goes from just an external excision to an intracranial excision, where we do a coronal incision and expose this area and reconstruct it from inside out safely. So here's the operation where we take out this lesion and we follow it up until we can take it out to the very top. And there's the sinus tract that we saw, the gap where it was taken out. And here we are. Now, and the worst case scenario for these kind of problems, midline problems, is this kind of problem. These are 5 children that I saw in one day in a clinic in the Philippines. On one of my trips there, one of our missionary partners brought these children in, and all of them have some version where it's not from the outside in, it's from the inside out, where there's a cranial bone defect and the brain is herniating out into the nasal sinuses and forehead. So that require a cranial, intracranial approach for all of these children to repair them. Now, as we shift downstream, craniofacial moves down to the lumbosacral area, and this is the myelomeningocele that we take care of. I partner with Dr. Tom Moriarty, and we have a fairly good series of over 100 patients that we had with no leaks. And basically, we take off this soft tissue structure, and the lining of that is the neural tube, and that's reconstructed by neurosurgery. And then we come back. Here's the closure of the neural tube here, but we wanted to protect it as much as possible. There's no bone that developed in this baby. These are the side walls of the vertebral columns. And so we protect them with the muscle, adjacent muscle. So we elevate muscle and skin flaps out to the sides. And this can be a challenge in these little tiny babies sometimes. And that way we have muscle coverage in case they have a leak. And oftentimes neurosurgery will put in a intracranial shunt temporarily. Now, moving over to hemifacial, one-sided facial deformities, I want to present to just Goldenhar syndrome as the most common one we see here in Kentucky. And for unilateral lesions, but it's interesting, they involve the ear, mandible, facial nerve, and face. So let me take you through a case of that. Here's a typical child who has hemifacial microsomia, we call it. And you can see an upward cant to one side. And the reason is this mandible on this side is not growing. And here you see the normal-sided mandible and the involved side on the right, where this is just not advancing and growing. So the maxilla doesn't grow, so you get an upward cant to the occlusion. Now, out of this area of the ear comes the facial nerve, and it has no way to egress. So we don't know how well that's developed sometimes, but in this particular case, he had complete normal function, but oftentimes one or many or all the branches are deformed and not working. So something to think about too, and that may require a facial nerve reconstruction. Here you can see the ear is not developed in this child, and but strange enough, the facial nerve has come out through this area to innervate the area. This is a problem I see from time to time It can be deceptive as to what it is. You may find it just very subtly asymmetric, or you may have a more severe case like this where there's facial atrophy. This is called Romberg's disease or Perry-Romberg syndrome. So I used to treat these with free tissue transfers to put tissue in here to fill it in. But if we can get to them early, we can sometimes, we think, halt the disease process with just subcutaneous atrophy. Here you can see the teeth. Here's the braces that are exposed because she doesn't have the soft tissue to cover them. But just in 3 treatments of autologous fat transfer, we use our own fat and liposuction it manually, spin it down, and re-inject it. And we're doing this for all sorts of reasons. But in teenagers and children, the fat grafts take well because we think there's more stem cells involved that perpetuate the growth of this fatty tissue. Here she even has a dimple that came back, and after 3 treatments over the course of about 2 years. A little bit about microtia I want to talk about. It's a very challenging area to address, but you're going to see these come through your office and what to do about them, and also ear deformities from trauma. So let's touch on this just a little bit. This is a child with microtia. This is type 3, where it doesn't look like an ear at all. 1 and 2 have the semblance of an ear, but when we get to more advanced 3, there's no ear there. So here we have a little canal, maybe a little auricular remnant, a little bit of a lobule. So I do 2 techniques. So 1 with a rib graft, or 2 with this material called MedPore, and it comes into in a 2-component device, and then we implant it, and we can shape it depending on the size of the other ear. We try to put this off till they're about 7 years of age or so, when their ears have pretty much reached their adulthood size. So let's go through that operation. Here I put the implant in where it belongs to, based on the contralateral side. There's a vessel that flows up here called the superficial temporal artery and splays out. And I excise this flap. It's called a temporal parietal fascial flap. And then I transpose that over this construct, and that'll be, it will totally encase that. Here you see it. And then the next procedure is to skin graft it. And then we suction it down, and it has this ear that I could never get as well with just rib graft itself. And this is 1 stage. So it's great. They can be exposed, and they can start spitting out some of this MedPore, which is one of the risk factors, but that's on more the exception than the rule. And so it's a common procedure done around the country now. Here's another child that we did, same thing, type 3, that doesn't look anything like an ear, of the Tanzer classification for microtia. And so we move through and reconstruct to the auricle. Okay. Now here's a traumatic case where this was a dog bite injury. And it's rare that I see this removed, but with trauma and infection, he lost the portion of his auricle. So I use the same type of material, but I'll use a portion of the MedPore, use the same flap that we talked about before, and to reconstruct that. And here is a post-trauma injury, a loss of majority of the ear. We do similar graft in there. It's early on, and it's a settle down, has to require some minor revisions. And then we get to this point where we have a fairly acceptable ear, made even better with an earring. Now, in speaking last, one of the common problems we see are these prominent ears. The ears are totally normal, but they're a little prominent. And we saw that overprojection. So we manage these children simply with an otoplasty. It's a posterior approach. And you can argue that, well, these ears are abnormally large, but 85% of the ear growth occurs in the first 5 years. So these children just have to grow into the ears, and eventually they will, and they'll look rather normal. But the vertical height of these are roughly 5.5 to 6 centimeters, and and that's normal. And so we just rotate them back, recontour them, and it's an outpatient procedure. Thanks. Everyone was very quiet out there. I heard no one, so that's good. And but thanks for your patience, and hopefully that was understandable to you. And Mark, if you're there, we can take questions now.
Sure. So first question, for small cutis aplasia defects, less than a quarter size, on otherwise normal infants in the newborn nursery, should we go ahead and consult peds plastic surgery?
That's not necessary early on. That's something you can wait on later, because in the growing cranium, sometimes you end up with a wider scar and you got still another problem to deal with. So I let them mature before in their teenage years, usually, unless it's really dramatic. And then we come back with but a lesion that small, we can address either early on or in the teenage years, but it's not an emergency. Okay.
And then for vascular hemangiomas, what's your opinion on best time to refer them?
As soon as possible. I meant to get into the propranolol issue, but you know, Mark, many people are very anxious about it. I have patients that have been in the hospital, hospitalized to start the propranolol, but as long as you use it, I think, in my opinion, in the safe boundaries, which to me is less than 4 milligrams per kilogram per day in 2 to 3 divided doses, that I could safely carry them through that without the worry about having complications with it, with exception of asthma, of course. But I like to see those early on so I can prevent the penetration of the hemangioma and destroying the skin, which is, especially in the face, is needed for the reconstruction.
And would that be on extremity hemangiomas also?
Not necessarily extremities, because I've got plenty of tissue to work with there, so it's not as critical a problem. So I don't always subject them to the risk of propranolol, but I have a very good comfort level with propranolol after using it so much. We've been using it for a number of years now, and I'm finding out more of the community, they're already on propranolol when they come to see me. So that's good to see that other clinicians are starting to become more comfortable with starting it early on to prevent the complicated reconstruction.
Okay. All right. Those are all our questions. So thank you, Dr. Cheriker, for your time in the lecture.
Okay. Thank you, Mark. Appreciate it.